Hello, hello. Here is Jean Louis Vincent. I have the pleasure now to speak about the COVID-19 related mortality. It's actually a complex topic which raises a number of questions. Very often, we do not know what the ICU patients die of. If we look at the literature, we know that about one third of patients admitted to the ICU for COVID-19 will die. And perhaps about 80% of patients who require mechanical ventilation. Of course, the numbers can vary, but it's between 70 and 80%, perhaps a bit less now than some months ago. But what is death due to? Respiratory failure would be the obvious answer, but if we think about it, we give oxygen, it doesn't work. We give high flow oxygen, we give CPAP, we use non-invasive or mechanical ventilation. We can go to ECMO, VV ECMO, VA ECMO. Why would the patient die? Is it renal failure? Well, we have renal replacement therapy. Is it shock? Well, shock is sometimes a bit underestimated in COVID because the four types of shock can be observed. It could be distributive with what we call cytokine storm, like in septic shock. It could be obstructive, like in pulmonary embolism. It could be cardiogenic. I am particularly worried about hypovolemic because some doctors looking at the chest x-ray give a lot of diuretics, they fluid restrict patients, and then when they need to intubate the trachea, there may be severe cardiovascular collapse, actually due to severe hypovolemia. But usually, shock is not very severe. Neurological complications, they can happen, but they are not usually a cause of death. And even the coagulopathy, the bleeding, of course it's common, but it's rarely a cause of death. So you may say patients die of multiple organ failure, but again, we can support the organs in general. So we need to bring an ethical component. We wrote, Arthur Slutsky and I, this piece a while ago, before it was a real crisis. And we say, just imagine if your ICU is full and there is still a surge of ICU patients. Then we arrive in the principle of distributive justice. All patients should have the same rights. Of course, we will try to transfer patients, we will try to limit elective cases, we will try to use the coronary care unit, the recovery room, the pediatric ICU, and some other patients may not be admitted in these other units. Okay, we may try to increase the number of beds, we may try to increase the number of respirators, even use one respirator for two patients. We will try to have more nurses from the regular floors, but still, there is a point where we cannot provide proper care to everyone. So we need to go into the concepts of adapted therapy, proportional care. We will have to make some difficult decisions. If we expand the number of ICU beds, there is still a point where we need to make difficult choices. We may have to keep patients who are not too sick outside the ICU, but we may have to make difficult choices within the ICU. For patients who have a poor prognosis despite ICU care, and we need some prioritization based on age or rather life expectancy, better concept, underlying illness, comorbidities. Some people would like to use severity of the disease, SOFA scores, to be more consistent in the decisions, because the decision process should be the same at 10 o'clock in the morning and at 3 o'clock in the morning. We know what should not influence the decision, and very importantly, we should not apply the principle of first come, first served. This is very, very important. If the ICU is full, we cannot just say, sorry, we have no bed available, go and look for a bed elsewhere. There are a number of papers on this, and I very much like this paper from Emmanuel in the New England Journal of Medicine, where they explicitly discussed it very well, saying it should not be first come, first served. Otherwise, you penalize those who may live further away from the hospital, those who waited a bit longer to avoid disturbing people in the hospital or other reasons. So we need to go back in the ICU and perhaps give up in some patients. Withholding, withdrawing, ethically are both acceptable. Very important element, because in some countries it is sometimes difficult to apply it, sometimes difficult to stop treatment. And yet, in either case, when we withdraw from mechanical ventilation or ECMO, we decide not to use this treatment from now on. So it's like withholding. We decide upon the treatment that we will give in the next minutes. In Belgium, there is a consensus that we published a while ago saying that we could actually increase the doses of sedatives even in the absence of discomfort if we think that there is no other option than death. And in the case of pandemic, we may actually have to use it more liberally to make the bed available sooner. It's very strong concept. But ethically, if we want to provide treatment to those who could benefit the most, we have to use it. It's rather difficult because we have to treat not only COVID-19 patients, but also other patients in the ICU. This was apparent in Italy, for instance, where sometimes people realized that they were keeping their beds for COVID-19 patients, but other patients had to come in the ICU actually were not accepted. That's unfair. There are other patients with peritonitis, with other forms of cardiac or respiratory disease who need to go in the ICU. And even when we speak about using ECMO, think about it. When there is a surge of patients, it would require too much work, and we would prefer to save more lives in severe respiratory failure, and we don't want to decrease the quality of care of the other patients. So you will see this piece arriving in critical care soon. So we need to discuss it and have these discussions with the group. It's not when the crisis is there that we need to improvise. I like this paper from the ACCP stating that without a triage plan, patients may receive critical care resources by random chance or a first come, first served basis, will likely lead to overall worse outcomes across the population and more individuals being denied critical care. Very important statement. So don't say the ICU is full, there is nothing I can do about it. We may actually have to take a ventilator from someone who is already on mechanical ventilation to give it to someone else. And we need to look at this scheme. The chances of survival are going down with frailty, age, comorbidities, but with mechanical ventilation, you could save some lives when these elements are not too severe. But when the situation is severe, it is just futile therapy. This Belgian woman, 90 years old, said, keep it for the younger. It's very important because our physicians, the younger physicians in particular, may actually find it very difficult because now we will withdraw life support because we need the resources for someone else. It's a team decision. Senior staff physicians should help the younger ones. Think at this New York physician who committed suicide. These difficulties have to be taken into account. So the mortality due to COVID, it's difficult to assess because perhaps we exaggerate the number of deaths due to COVID. Skydiver who forgot parachute dies of coronavirus because he was tested positive. We still have patients who die from something else and they may be actually tested positive. In Belgium, we had a number of positive cases, but I have no time to discuss it because my time is almost over. I will only end up by saying that to understand the pathways to death, as we published it in the Lancet, many patients die because we do not have the opportunity to apply treatments. Patients may not be admitted to the ICU. Patients may not be treated by mechanical ventilation. Patients may not be treated by ECMO. So we need to collect this information. What is the pathway to death? Is it predominant terminal organ failure, proportionality of care in the dying process, involvement of COVID-19 in dying process? We need to take this information into account. I'll stop here. Thank you very much.